Welcome back to Section 3 of the INTREC lecture on education, socioeconomic status, and health. We're going to move on to the topic of measuring socioeconomic status. And we're going to talk about some alternative approaches to measurement and some considerations when you're choosing a measure of socioeconomic status. As we've discussed, there are many different dimensions of socioeconomic status, education, income, occupation. We also talked about wealth and employment status. So what's the right way to measure this? The first thing to do before you try to choose a measure is to think about why exactly you think socioeconomic status should matter for your health outcomes. What are the mechanisms that make the most sense, that seem the most plausible to link socioeconomic status with the health outcomes that you are interested in? So for example, you may think that medical care is the really critical mechanism. If this is around, for example, treatment or management of a disease that requires intensive medical care, then medical access might be the really critical mechanism. On the other hand, you might consider material adversity the really critical mechanism. So you may think that, in fact, having healthy housing, if you're studying a host of health outcomes, that you think healthy housing is really critical, and for that you simply need enough money to buy healthy housing. You may believe that behavioral influences like diet or physical activity, smoking patterns are the most important mechanisms via which socioeconomic status influences health. Or depression, stress, psychological trauma, social connections, social influence. For each of these, you can think about subsequent mechanisms. So material adversity is going to influence housing, food quantity and food quality, your exposure to violence, your exposure to weather events, behavioral influences such as diet, smoking, exercise, alcohol use, medical adherence. And it's worth separating medical access from medical adherence and thinking about these separately. Help-seeking behaviors. When you think about these pathways, it's important to recognize that although we can talk about them separately, they're very interactive, i.e. they intersect with each other. Material deprivation has worse consequences when coupled with psychological disorders. In several studies, we can see that whatever the consequences of material deprivation, it's much exacerbated if you're in a context of exposure to violence, extreme psychological distress. They're reinforcing, so lack of dental care may make it harder to find a job, creating further material disadvantage. Prestigious friends help you find a high-paying job and access to the best medical care. Depression impairs your ability to eat healthy foods and exercise. So these mechanisms are reinforcing each other. On the other hand, they may also be redundant. It may be that any single disadvantage would be sufficient to induce poor health, but in fact, people tend to have multiple disadvantages. So people with low education are likely to have low income. So having either low education or low income would result in the poor health outcome, the adverse health outcome, but in fact, people tend to have both. So what this is very important for is thinking about how do we achieve a public health change? What could we change that would improve health? Changing one of them might not be enough because having either disadvantage would be enough to cause poor health. There are many different approaches to measuring any particular dimension, and there are both advantages to harmonizing using measures that are standardized across studies and contexts and countries, and inevitably, though, there are some aspects of socioeconomic status that are unique to context, and that you have to recognize and understand the particular context and community in which you're trying to measure SES. So this is an example of a measure of education in the United States from the Health and Retirement Study. So first they ask, what is the highest grade or school or year of college you completed? And they let people report that they had no formal education, the number of years of schooling they completed, if they completed primary, secondary school, how many years if they completed college or post-college training. In addition, they actually ask about diplomas, because in the United States it's very common to take a test that's called a general equivalency degree, and people treat this as if it's a high school diploma equivalent, although it seems the evidence is a little bit suggests that in fact the earnings are not as highly associated with the GED, but it is an important credential. And you can also attend 12 years of school, which is the typical amount of time required to complete high school in the United States. But you can attend 12 years of school and not complete the credential. So the HRS asks, in addition to the number of years, they ask about the credential. Did you get a high school diploma or pass a high school equivalency test? And they ask a diploma, a GED test separately, or no, I didn't complete this. It's worth contrasting that with the measure from the China Health and Retirement Longitudinal Study, in which these are the possible responses. So they ask, what's the highest education level of education completed? And they have the following response options: illiterate, did not finish primary school, but able to read and write. A homeschooling option, which you notice was not really asked in the Health and Retirement Study question, and then graduated from various levels. What I want to emphasize here is that the GED may not be relevant in contexts where there is no such test, but in the United States it is a really relevant credential. So you have to understand what the educational system is in the place when you're measuring it to choose what the response options should be, and then consider how those correspond with educational standards in other contexts. So it is good to use a harmonized measurement so you can compare results cross-nationally, but every context has some unique features of the educational system that require additional assessments. And very often when you're actually undertaking analyses, you will have to collapse categories in order to compare across contexts, or because you have very few individuals within categories. So very common categorizations, for example, include 0, 1 to 3 years, 3 or more years. This would be in a very low education setting. Less than 12 years, more than 12 years. Bachelor's degree, master's degree, doctoral degree. I've seen each of these used in populations in which these were actually the meaningful categorizations, just depending on the population, whether it was very low education, sort of a typical US population, or a very high education population. In addition to years of education and the credential, I want to mention important dimensions of education that we often disregard and we don't focus on, but in fact they may matter a lot for health. One is quality. So education is not, completing a year of education is just clearly not the same regardless of where you complete education. Resources like teacher training, the amount of money available to the school, the number of days in the school term, like the actual number of days that the school is open, the hours in the school day, the number of other students who are in a classroom. So if you're in a class with 40 other students versus a class with 10 other students, the quality of education and what you learn may be very different. So if we think that the mechanisms by which education is influencing our health outcome have to do with what you learn, with, for example, literacy skills or cognitive skills or knowledge, then educational quality is very important. Another dimension of this is the socioeconomic status of other students in the class and the school. The status of the training institution. Attending a high-status institution may improve the value of credentials and also improve the social ties you create. So, for example, if you go to college at a very high-status university versus a low-status university, you may form a different set of social relationships, a different set of networks that are of value later. And the credential of your degree may have more, bring you more earnings in the labor market. And it's also important, and I think very under-researched, what are the consequences of education outside of traditional primary, secondary, and tertiary schooling. So preschool, kindergarten, these two forms of education, in the questions from the Health and Retirement Study, they would not have counted as education. So it is very common for U.S. children to attend kindergarten and to attend preschool. So it can amount to at least a year or more of additional schooling, which is not captured in the typical educational assessments. Employment-based training. Many workplaces provide some sort of training, and that may really have health consequences because people learn skills that are important. Continuing education, compensatory education pursued by people who did not complete conventional schooling. The GED that I mentioned earlier is an example of this, but there are many other domains. These are dimensions of education that may have important health consequences, but we do not focus on them very much, typically. And finally, parental education. Parental education is very important in both influencing how much education you get, but also probably influencing things like your literacy level, your cognitive skills, your knowledge, and so forth. So, choosing measures. So different measures often correspond with different constructs, and income, so for example, income from paid work may have very different health consequences than income from social insurance payouts. And there's really just a little bit of evidence suggesting this, but there's been a very little research on this topic, but the research there is suggests that in fact earnings have different health consequences than non-wage income, and that in fact even things like how the money is distributed, if it's distributed in a lump sum at a predictable time point or if it's distributed in small amounts, these things influence the health consequences because they influence how the money is used by the recipient. All right, I want to talk a little bit about the intersection of race, ethnicity, and socioeconomic status. Race, ethnicity, and socioeconomic status are distinct concepts. Individuals of any ethnicity may have more or less education and more or less money. However, they are very often correlated because of historical patterns of discrimination and cultural norms. And even in the absence of de jure segregation, by which I mean segregation by law, or explicit discrimination, by which I mean that someone says we will not employ or we will not provide care or we will not provide this resource to people of a particular ethnicity or race, even when there's no legal discrimination, legal segregation, or explicit discrimination, individuals in an historically discriminated against ethnic group are likely to receive worse education, have lower incomes, and lower wealth. This has been very well studied in the example of African Americans in the United States, and so this is the from the Braveman paper that was in the reading list, and I think it's informative because it's so powerful and well studied here. So this is a table from the Braveman paper about showing mean family income by education level and race ethnic group among adults in the National Health Interview Survey. And what you can see is that, so this is education level over here, less than 9 years, 9 to 11, and this is income, mean income, among blacks, Mexican Americans, and whites. And what you can see is that for people with the same level of education, for example, with less than 9 years of education, black mean income was $15,000, Mexican American mean income was $19,000, and white mean income was $23,000. So even with the same level of education, whites had much higher incomes than Mexican Americans or blacks. So the key point here is that there are very strong social inequalities by race ethnicity, and accounting for one dimension of SES is probably not sufficient to make people who are historically discriminated against statistically similar to people who are in the historically advantaged group. In addition, these measures of socioeconomic status are not as highly correlated as you might intuitively think they are. So, for example, this is showing the correlation between poverty level and education within by race ethnic group. And the key point here is that the correlations between poverty and education are in the range of 0.4 to 0.5. These are pretty modest correlations. I mean, they're not trivial, but they're definitely not measuring the same construct. So what that means is that in any actual analytic plan, adjusting for poverty is not enough to control for educational differences or vice versa. So if you adjust for poverty, then you still anticipate that there may well be differences in education. And if you adjust for education, there still may be differences in poverty level. So adjusting for education and income, adjusting for education is not sufficient to control for differences in poverty and vice versa. Now let's look at how wealth and income intersect by race. And this is another table from Braveman's article in which we have by income quintile, so the lowest, second, third, fourth, and highest quintile of income, the average wealth of white non-Hispanic families. And what you can see is, of course, a strong gradient where wealth in the lowest income quintile is lower than wealth in the highest income quintile. So wealth among whites in the lowest income quintile is only $24,000, but wealth in the highest income quintile is $208,000. Now, I'm just going to ask you to pause and guess what the median net worth for Blacks and Hispanics in the lowest versus the highest income quintiles might be. Do you think it's going to be about the same as the median net worth that we see for whites, or do you think it'll be different? So stop and just take a guess at what those would be. So fill in the numbers for the low income quintile for Blacks and Hispanics and the highest income quintile for Blacks and Hispanics, knowing here that you have the numbers for whites. So if you have your guesses, keeping in mind that these are data from the United States, here are the numbers. So in fact, median net worth or wealth among Blacks in the lowest income quintile is only $57 compared to $24,000 for whites, and median net worth for Blacks in the highest income quintile, only $65,000 compared to $208,000 for whites. So these are remarkable differences in wealth even within income quintiles. All right. So when you're choosing measures of SES, there are several dimensions that you have to consider, decisions you have to consider. First, the things that we've really just talked about. So what type of resource you're going to think about? Money, education, social status, occupation, what is the category of resource? Next, you need to consider absolute versus relative measures. You also need to think about when in the life course do you think this is important? Is this something that is important very early in life or much later in life? And also individual versus contextual measures. So let's go through those very briefly. SES measures across the life course. Typical measures are taken at only one point in time, for example, now or last year, a particular moment, like what was your income last year? However, the empirical evidence suggests that, in fact, it's not just last year that influences your health, that health develops across your life. You accumulate disease, you accumulate physiologic changes, and so it's important to consider how socioeconomic status from literally when you're in utero through the current time period may each affect your health. It's also important to recognize that variability or instability may matter. So periods of extreme poverty may be very harmful even if on average you have high income and sufficient income. And finally, trajectory. So net increase or net decline may matter for your long-term health. And this is particularly important to consider in the context of communities where average socioeconomic status is changing very rapidly. So for individuals who have lived, older individuals who've lived through major economic transitions, it's important to understand that it may not just be their current SES, it may really be their early life SES, or it may be the trajectory across time, or literally their change over time. That's very important. So this is sort of a plot of showing socioeconomic position from birth, childhood, adulthood, and old age, and particular measures and how these become physiologically embedded. So in the prenatal period, there may be, you may manifest this through low birth weight, growth retardation. In childhood, the environmental and educational conditions start to influence behaviors. Certain behaviors are really patterned by, the decisions have largely been made by early adulthood. So decisions about smoking are usually made in adolescence, very early adulthood. These are critical time periods for health behaviors. In adulthood, occupation and income become more important. And in old age, income and assets, wealth seems to be more important because it influences factors like medical access. I'm going to skip that slide in the interest of time. So this takes us back to the importance of the age patterns that we saw in India and that will emerge or have emerged worldwide, where because this age pattern of education, where younger, more recent cohorts have much more education than older, earlier birth cohorts, suggests the tremendous socioeconomic changes that have occurred during the lifetimes of these individuals who are older. So even if they now have stable incomes, they may well have been born into time periods when they had much lower incomes and greater poverty. Intergenerational transmission of socioeconomic status is very strong in every context. In the United States, each 10% change in the earnings of the father predicts a 6% change in the earnings of the son. And so with this level of stability, it actually would take 5 to 6 generations of descendants for a family at the poverty level to get up to approximately the average national earnings level. And furthermore, intergenerational transmission, the link between father and child's socioeconomic status, is actually stronger in poor families than in wealthy families. The extent of this stability across generations depends on the time and the country examined, but there's always some level of correlation. So wherever you end up, it's somewhat influenced by what your parents had to give you with respect to their own education, their own income, their wealth. So when we think about socioeconomic status across the life course, it's important to consider when we think actually matters. What are the important time periods? One model of socioeconomic status and how and when it matters is a latency model. So it actually, in the latency model, the idea is that there's a time period which is very important, and your socioeconomic status during that time period is the most influential, and it doesn't matter what happens afterwards. Usually this actually emphasizes very early life, prenatal exposures, early childhood exposures. So there's a critical time period, and if you're disadvantaged during that time period, you can never make it up. So for example, there are episodes of growth, of fast growth during childhood and key developmental periods. And if you're disadvantaged during those time periods, you never make up the growth. So that's a latency model. Another model is a social trajectory model. So the idea of social trajectory models is that, in fact, early life factors don't matter so much, but they do influence your subsequent exposure. So education is important because it influences your income in adulthood, and your income then translates into adult health. This is an important thing to distinguish, because if what we actually think is happening is that socioeconomic status in early life influences you, regardless of what happens later, then we have to intervene in early life. We must intervene to prevent the ill health consequences. We must intervene early on in life. However, if you think that what matters is that early life disadvantage begets or gives rise to adult disadvantage, and it's the adult disadvantage that actually becomes physiologically embedded, then we can intervene later in life. It really gives us hope for intervening in people who've been socioeconomically disadvantaged to help promote better health even in adulthood. A final model, which I think in many cases is the most plausible model, is a cumulative model. The idea is there are times that across your life course you encounter adverse experiences, and each of them has some small biological cost and becomes slightly physiologically embedded, and they add up, and over time they accumulate into disease. This model suggests that if you intervene early, it would have the greatest benefit, but if you intervene late, you can still help. So under the cumulative model, each exposure period causes a little bit of incremental harm, but if you intervene early, it's great because you prevent all that harm. But if you intervene late, you prevent some of it and you can help reduce socioeconomic inequalities in health. There's really abundant evidence that early life has independent effects on cardiovascular disease. The effects of instability are uncertain, but I think this is a very important question as we look in contexts where there's been tremendous socioeconomic change and socioeconomic revolutions in the life course of older adults. And the question of trajectory and whether adult SES is more important than childhood are very, very difficult to actually get a real handle on. Empirically, it's very difficult to do that work. I want to mention absolute versus relative position, but I think there will be a subsequent lecture in which there's more attention paid to this, but it is an important dimension of socioeconomic status to ask, is it healthier to be the best off person in a disadvantaged group or the worst off person in an advantaged group? It's probably preferable to be the best off person in an advantaged group, but in truth, both relative and absolute deprivation probably matter for many outcomes. And it may not be important to parse this precisely, but it's important to recognize that changing absolute resources will not necessarily eliminate harm intrinsic to low socioeconomic status. And finally, individual versus contextual socioeconomic status. When I say contextual, you can say, what's a context? Well, we don't think that it's only your own socioeconomic status that influences your health, because you draw upon the resources of the people around you. And those people, the contexts are defined by many different domains. We can think about national contexts. We can, of course, see how national contexts influence health, regions, states, cities, neighborhoods, government units, and there's extensive research on some of these and less extensive research on others. So, of course, there's a fair amount of cross-national research in the United States, across states or provinces in other countries, neighborhood research. There are also many contexts that are not geographically defined. So, for example, schools are a very important context for socioeconomic status and the influence of health. Workplaces, hospitals, your home, who you actually live with, and peer groups that are much more fluidly defined influence health. Here is just an illustration in the United States of how profound the geographic patterns are. In the United States, this is for stroke mortality, and what you can see is real the deeper purple areas are places where stroke mortality is higher. And what you can see here is places where very high levels of stroke mortality prevail. And those are down, this is at the county level. So these are down to very small geographic areas. There are huge disparities defined by geography. And we don't actually understand very well what drives those disparities. But similar types of geographic patterns in health have been demonstrated in many contexts for many outcomes, in particular cardiovascular. And I think there'll be a subsequent lecture on place-based quality. Okay, measuring socioeconomic status in summary. There are multiple dimensions, and you need to think about the multiple dimensions because they cannot stand in sufficiently for each other. It's not enough to say adjusted for education, and therefore I've adjusted away socioeconomic differences. The most relevant measures depend on the hypothesized mechanisms. So when you're choosing the measure, you want to think about what are the mechanisms by which I think socioeconomic status might influence health in this context, and has the measure of socioeconomic status that I chose captured those mechanisms. You typically measure current individual level, but it's important to consider multiple aspects that might be relevant. Both educational resources and financial resources, when in the life course the measure occurs, absolute and relative contrasts, and contextual and individual. And with that, we'll stop section 3. Thanks.